Good morning, everyone. First thing to note, I'm a bit of a wanderer, so if I move off mic and you can't hear me, just wave at the back. I thought it'd be useful to start with what my team do, and I'm just wandering off again. I will try and anchor, because we have a very large remit as a national team in estates, and as you know, estates and facilities covers a huge area. But today I've got with me Emma and Phil, or they're here in their own rights, I'm also here, to talk about Soft FM. And they've been instrumental recently in the new cleaning standards, the NHS Chef 2021 regional heats, supported by Craig, which will go into the final fortnight at the end of the month into next month, which is really exciting, and an opportunity to showcase the hard work and the value of our workforce. And this is something we are very proud of, and I am really proud of the team for bringing it together and creating the energy and dynamism. Now, there's a broad range of things there, and there is a risk that if you come to a estates conference, I will be speaking, and you will have heard me talk about the same thing over and over and over again, and that's not of any benefit to you, and it's a bit dull for me as well. So I'm going to take a little bit of a risk today, although I will be talking about ventilation, because that's something that has been preoccupying myself and my team. So today, I was going to give you the view of what a building is from the perspective of an architect, which is actually where I started. So you think of a building as a home, a workplace, a place of leisure. Architects think of a building as a climatic modifier. Now, when we study architecture, we're drawn attention to a little fug that sits around us. Part of it is psychological, it's our personal space, and part of it is the air that hangs onto our bodies as we move off mic, the friction from our clothes. And this has our own smells. It's an insulation. It actually protects us. So when airspeed increases and strips away our fug, then we experience chills. And similarly with temperature, humidity, if the humidity is too high, we can't sweat, therefore we can't cool down, and you will have been experiencing this in PPE and in face masks for the last year or so. So we create buildings, and this is a great book if you ever fancy reading about humanity and architecture of humanism by Serge Chemaeff and Christopher Alexander, but it creates the concept of the building as an entity in which we exist. Now, the reason why I started there as a building modifier is because fundamentally, whenever we put in an intervention to protect us from heat, cold, humidity, then we've changed the playing field. And we've talked about only meeting each other outside. The building modifies that environment. So I've included a slide here from the SAGE EMG report, which just talks about the modes of transmission. And if you intervene in any of those modes, then you have an opportunity to enhance the built environment for its occupants. And I've been heavily concerned with droplets and aerosol and airborne transmission, so in ventilation terms, and working with my team here on the cleaning of fomites and frequent touch points and other areas. So that's sort of those controls which we use, the HSE's standard approach, take out, if you remove elimination, if you remove COVID, so you only have patients that come in that don't have COVID, you've solved the problem, you don't need the ventilation because there's no COVID. I know that's simplistic, but that is one of the streams which we looked at for surgery. So you control, you eliminate. And then there's PPE, you'll notice, is the lowest form of protection, relying on the individual. But that's been one of our safety mechanisms of last resort. Bits of this slide, if you've seen me speak before, you will have come across. Ventilation dilutes COVID virus and other viruses, and as we move forward over the next few months and over the next 5 years, we will be talking less about COVID-19 and more about seasonal viruses, because we will have a mix, and COVID will become endemic, and we will be looking at all manner of winter respiratory viruses that we need to control for as part of that normal way of living, and look at different mechanisms by which we control them. Space, ventilation will be those, but also we might take different choices when we look at the incident rates in the population. So you might have less social distancing in waiting spaces if there's 5 cases per 100,000 rather than 1,500 cases per 100,000, as you find in schools at the moment. So you get that variance, and you look at all of the mechanisms and the controls rather than looking for one, ventilation, as your silver bullet. However, it's worth noting that if all our buildings were built to the current or even the last HDM, and we operated those management principles, and when we undertook changes, we deployed those air change rates, we would have much less nosocomial transmission in healthcare environments than we currently do. And this is a real challenge. And it is really, really hard to retrospectively fit ventilation into buildings, because it's big holes with ducts, air noise, penetration of fire compartments, huge expense, very, very disruptive. And at the time when we are trying to increase our clinical activity to recover the activity lost, what we don't want to do is close dentists down so that we can enhance their ventilation when we're trying to recover the limited activity. So there's that balance between what interventions can we undertake and what interventions are practical whilst trying to improve people's quality of lives and their health and well-being. And just to note, one air change does not change all the air in an hour. It changes a bit of the air because it dilutes and it mixes. So you get a sort of a logarithmic effect where over time the changes keep diluting and keep diluting. It's one of the principles of homeopathy, not that I agree with it, but actually you will always have an element left. And something that I think is really, really important, if you've got no ventilation, don't go in there. The building regulations require you to have ventilation. Spaces that have no air changes are not right and should not be occupied. I'll be very quick on this. You've got the slides. The principles are big droplets, medium droplets, aerosol, big droplets, splash, fall to the surface, clean up. Medium-sized droplets are affected by gravity. They fall, and after, we believe, around 10 minutes, you can clean them up. And then aerosols hang around forever as part of the environment, unless you do something to dilute them. And the longer you're generating aerosols for, the more aerosol you have. And one of our big challenges when we've looked at this scientifically and as engineers and in SAGE is we don't know how much virus you need to infect a person. And if we did, we wouldn't know which person is affected differently. So everybody's different. So one person might be more susceptible to the other. So you've got the generation of a virus within the atmosphere, and you don't know one of the most basic facts about it. So when you're trying to plan for its removal or dilution, we're trying to get to as close to zero as possible because we don't know whether it's a tiny component or a big slug of virus in your mouth. So that's one of the little challenges around that. What I wanted to talk to you, and then these are the questions. So when you come back to me a little bit later on, these are the things I want us to think about and have that discussion on. So I've talked about ventilation being one control of many, cleaning, separation, isolation. When we think about that IPC risk assessment methodology we have for the NHS now, it's really worth thinking about the patient's pathway. We hear in the news both complaints and celebration that you can't get a face-to-face GP appointment, because both are valid. Personally, I find it a great thing that I don't have to schleck across to a different part of the county to see a GP. I can have a conversation and move on. It's still there. But other people need that face-to-face. So, and certainly if they're looking at something on your arm, they do need to see it. But those opportunities we have to look at what adds value and what detracts from value in the patient pathway. How many visits do you need to a healthcare environment, and how many can you do without, is a real opportunity that we now have. And talking to the net zero carbon team, and you saw those different parts of the pie chart. Well, buildings is one part. Acute healthcare buildings use more energy than primary care settings because they're more complex and more advanced. And they have N+1 resilient systems like generation systems and others, electrical generation. So if you have less buildings because you're doing less activity in buildings, you're positively impacting on the carbon. If you're not traveling, you're positively impacting on the carbon. So there's a lot of side benefits here, and our work streams come together in many different ways and support this sort of holistic view. And Fiona mentioned digitalisation, and that's an area that I'm to lead on, the digitalisation of the NHS estate. And this is really, really exciting because we ventilate buildings whether people are in them or not. And if you've got sensors that tell you that someone's in a room, you can ventilate it. If that fan runs 70,000 hours in a year, then it might need more maintenance than one that runs less. And then you can divert your resources and your controls on your airspeed and your energy on maintenance and the components into different areas that add more value to that patient pathway and that work stream. Air cleaning technology, I notice we are shadowed by it. This does have an important role, And Mike Ralph in my team is working with IMEC on a standard for air cleaning technology, because at the moment it is a self-regulated industry, and you don't necessarily know what you are buying or the standard to which it operates, because there aren't those standards available. So we will have, hopefully by the end of this month, a draft standard for UVC, and moving forward with HEPA, and those will be portable units initially, and then work to a standard for built-in units. And on built-in units, I just wanted to say, air handling systems use a lot of energy. In the NHS and in the United Kingdom, in the NHS, we do not recirculate air. Only fresh air comes in to our buildings and is distributed. Used air is exhausted and goes out. And that is a great thing from the perspective of control of infection. But from the perspective of taking warm air or humidity-controlled air and throwing it away when we've just put all that energy into it is a really bad thing. And we will really struggle to achieve net zero carbon if we don't think about the recirculation of air in our healthcare environments. And that's a big challenge for us. The new HTMO3 and ventilation that's just come out does not include recirculation of air, because we are not there yet with the technology to support us. We do have recirculatory air systems in ultra clean theatre hoods, where you have a fresh air and then a HEPA filter to create a working area. But that's very limited, and HEPA creates a lot of resistance to air. Therefore, you need to increase the air speeds. Therefore, there's a friction, there's an embodied energy problem. So UVC is a lower energy option that we will certainly be looking at for recirculatory air. I have stopped now. Hopefully that gives you some food for thought and the opportunity to ask some questions. But I was going to step away with that slide up. So thinking of your buildings as climatic modifiers. Thank you.